Good morning, and thank you for joining us this morning for Winship Grand Rounds. If you're an Emory University or healthcare employee and would like to receive CME credit hours for attending today, the login information can be found in the chat feature on the bottom of your screen. If you have any issues with this webinar or the CME login, please send Julie Hawkins an email or drop a note via the chat feature. This morning, we are pleased to welcome Dr. Lori Pierce. Dr. Pierce is currently professor with tenure in radiation oncology. In 2005, she was appointed by the University of Michigan Board of Regents to be Vice Provost for Academic and Faculty Affairs, a position she still holds. She currently serves as Director of the Michigan Radiation Oncology Quality Consortium, a quality consortium of radiation oncology practices across the state of Michigan that seeks to establish best practices in the treatment of breast and lung cancers. She's a member of the NCI Breast Cancer Steering Committee and previously served on the steering committee for the Early Breast Cancer Trialists Collaborative Groups at the University of Oxford. Dr. Pierce has published over 170 manuscripts and book chapters. She was elected to the National Academy of Medicine in class of 2018. In 2019, she was Woman of the Year by the United Way of Washtenaw County in Michigan. In 2020, she served as president of the American Society of Clinical Oncology, the largest organization of oncology professionals in the world. Thank you, Dr. Pierce, for joining us today. It is a pleasure to have you. Thank you.
Thank you so much, Dr. Torres. And actually, I would have liked even shorter, much shorter than that, but thank you. So good morning, everyone. It's great to be with you, although I wish, obviously, I could be there in person, but we'll make the most of this virtual arrangement. So I want to talk about the intersection of quality and radiation delivery and equity of care, two topics that are very near and dear to my heart. So as you just heard, I completed last year a year as president of ASCO. And the theme that I chose was equity, every patient, every day, everywhere. And you know, when you're voted president of ASCO and you're president-elect year, you get to pick a theme. And so I knew that I wanted equity as my theme. I wasn't sure how it would resonate with the oncology community, because at that point it was before the pandemic, it was before all of the heinous acts against people of color played out on the media. But it seemed like the right thing to do for me, and it turned out it was the right thing to do, I think, for oncology in general. And certainly equity in healthcare has been at the forefront of these past year and a half to 2 years. And when you think about equity in cancer care, I always say that the word equity is such a simple word, but it seems to be so difficult to achieve. And I think that's because there's so many factors that come into play that impact cancer health outcomes. And some of the factors I've listed on this word cloud. And of course, there are factors that lead to inequitable outcomes in general, and that also affect healthcare. And for the next few slides, I want to just pick a few metrics to emphasize how difficult it is for marginalized populations to access care. And this particular slide looks at the proportion of people living below the federal poverty level, and was taken from 2018 data. So it's before the pandemic. And as you know, but maybe don't know the numbers, you see that clearly there are many more Hispanics and Blacks who live below the poverty level than white non-Hispanics. And if you look at those who are uninsured, again, you know that the numbers are higher in the Hispanic and Black populations, but this just shows the magnitude of difference. And again, these data were taken pre-pandemic. I'm sure the numbers will be much higher now. When we look at the metric of infant mortality rate by maternal race ethnicity, you see that there's a higher mortality rate with Blacks and Native Hawaiian and other Pacific Islanders having higher rates of infant mortality deaths. When you look at race-based life expectancy, you see some very disturbing trends. And this is data from the CDC through 2014. I'm going to show you in a minute more recent data, but if you look at the 2014 data, you see that there's a loss of 4 years for Blacks and Native Americans compared to whites. And if you look at Asian Americans, fortunately, there's a 7-year improvement compared to whites. But the question is, why does there have to be a difference? Why is it that these numbers vary so dramatically by race and ethnicity? So this is the 2014 data. If you look at the 2019 and 2020 data, you'll see that there has been a further reduction in life expectancy in 2019 compared to the 2014 numbers that I just showed you. But what's even more interesting is that you see a further reduction in 2020 compared to 2019. And you see about 75% of this difference between that 1 year period is due to COVID, which of course disproportionately affected people of color. So again, 2019 shows a further decline in life expectancy for all races and ethnicities, but then you see a difference between 2020 and 2019. And that difference, when you break it out by race, ethnicity, and gender, you see that the greatest decreases in life expectancy were for Black males, Hispanic males, and Black females. And then I have to mention incarceration rates. We all know that there's a higher rate of incarceration for Black males than other races and ethnicities. When you look at the numbers, you see it's almost a 6-fold increase in incarceration rate for Black males compared to white males. This is very disturbing. And I have to say, as a mother of a 24, almost 25-year-old Black male, who is one of the most law-abiding, respectful, just delightful people, this worries me because sometimes our judicial system gets things very wrong. So this stark difference is extremely disturbing. Okay, so if we look at cancer, we have a lot to be proud of. We've, of course, seen significant improvements in survival in recent years, with decreasing death rates for men and women, largely driven by a huge drop in lung cancer deaths. And actually just last month, the American Cancer Society published their annual report, and it showed a reduction in cancer deaths by about 1/3 since 1991. And it's due primarily to early detection and treatment of lung cancer and decreased use of tobacco. So very much positive data in recent years. But of course, as you know, there is unevenness. When we look at numbers by race, we see the improvement is highly variable by race and ethnicity. Black males have both the highest incidence and death rate of any major racial ethnic group in the US. Black women for many years had a much lower incidence of breast cancer, and now the incidence is very comparable, but there's a 40% increase in death. And actually breast cancer is now the leading cause of cancer deaths in Black women. It surpassed lung cancer. And Black males, when you look at prostate cancer, have almost double the incidence of prostate cancer and over twice the death rate. So there is a clear unevenness in outcomes by race and ethnicity. This past December, I had the honor to speak at the Nixon Library as part of the 50th year anniversary of the National Cancer Act. And it was an amazing opportunity because when you look back at where we were as an oncology, as a field 50 years ago, and where we are now, it is just amazing, the progress. And so there was much to celebrate, but I had to say, I mean, I felt like a wet blanket that there's still so much that needs to be done. Here's the graph showing some of the numbers I just showed you before, showing the mortality rates by race and ethnicity. And clearly there is an unevenness in outcomes in our country. And there are persistent disparities in cancer care outcomes. You see this not only for race and ethnicity, we see it for patients living in rural areas. We see it for populations with lower income or educational levels. Wherever there is a marginalized population, those patients fare worse. And it was a very important thing, I thought, to highlight at this anniversary. And of course, many of these differences are due to hidden factors, which we collectively call the social determinants of health. And these factors, without a doubt, contribute to the inequities we see. So clearly, economic stability, neighborhood physical environment. Do people live in safe places? Are there toxins around them? Education, obviously very important, literacy, but higher education. Hunger, food. Can people access food? Can they access healthy options? Community and social context. Is there excessive stress? Are there support systems that people can have access to? And certainly healthcare systems where you have health coverage, provider availability, quality of care. All of these factors dramatically impact health outcomes. And certainly quality of care is a key determinant of outcomes. And I'll spend quite a bit of time talking about that. Robert Wynn, who many of you probably know, who's Cancer Director at VCU, has used the term community omics. He says that we must examine factors such as obesity, violence, poverty, stress in communities, the built environment, lack of exercise opportunities, and environmental pollutants on cancer incidence and mortality. These are the invisible factors. He's absolutely right. And then he goes on to make a point that this was at a National Cancer Policy Forum that he noted this in 2019, that we have to be aware of the intersectionality of interdependent factors, such that there's so much interplay between these factors. If you focus on one exclusively, and let's say you address that one, you may not see a difference in the overall outcome for a population because there's so many other factors that need to be addressed. And I think that's actually reflected quite nicely in this conceptual model that John Ianian, who was at Harvard for many years, and now he's been at Michigan for about 8 or 9 years, put together also at the same National Cancer Policy Forum, this model that shows the interaction, patient factors, community factors, health system factors, they all come into quality of care, which largely then dictates outcomes. Very important to note that they are all related. And then there's structural racism that I have to at least mention, in that it significantly impacts the distribution of the social determinants of health. And I found this simple model has been very helpful for me to kind of think about all of this. And so you think about the things that are visible, what's above the waterline, and those are the overt actions, the hate crimes, the things that just are heinous acts, and they're readily observable and people condemn them, which we must condemn them. But the issue is, what is going on below the waterline? What can you not see that then makes these things possible? What the implicit attitudes, the racial ideology, the institutional policy, segregation, these are the structural aspects that make racism possible. So it kind of helps me to realize that what you're seeing, we can see is the tip of the iceberg. Most of it is below the waterline. So what do we do? Last year, ASCO published its updated policy statement on cancer care disparities, and we noted 4 major overarching themes, which have really provided the framework for much of ASCO's equity efforts. And you see the main themes here: equitable access to high quality care, equitable access to research, addressing structural barriers, and increasing awareness and action. So I want to focus primarily on equitable access to high quality care. So social determinants of health, I've already mentioned that. Unconscious bias, where we as healthcare providers, we have to recognize our biases and not allow them to enter into our decision-making process. We have to recognize them, we have to address them so they don't bias our interactions with our patients. And this could be the topic for a separate talk. But then there are the patient care models that can significantly impact our ability to deliver care. And I want to talk about that. The Affordable Care Act has brought undeniable progress, no question about it. There's significant decrease in the numbers of uninsured. You see the numbers drop from 46.5 million in 2010 down to 28.9 million in 2019. We as cancer providers know the importance of cancer screening, and there was an increase in cancer screening second because of the ACA. And then with consumer protections, the ACA has brought new protections for cancer patients where there can't be coverage limits. So without a doubt, the ACA has brought undeniable progress. But again, there's an unevenness. That's the word I use a lot. There's an unevenness across our country, even with the ACA and Medicaid expansion. We know that there are still 12 states, one of which of course is Georgia, that have not expanded Medicaid coverage, so many are left without coverage. And the majority of these states, which are gray in this slide, are in the southeastern part of the US. And that's significant because that's where you see a disproportionate number of people of color living. So when we talk about improving cancer care delivery, we need to fully extend Medicaid coverage. And it's my hope that there is some way that the federal government can provide incentives to the states that have not expanded so that'll happen. But I suspect it's not going to be as simple as that. But we also know that there's need for additional models of care in addition to the ACA. And a perfect example of a model of care is the Delaware Screening Initiative, which was focused on colorectal cancer. And the paper that Steve Grubbs wrote about this back in 2013 may be one that you either didn't read or you've forgotten, but I want to bring this back up because I think this initiative is so important, and it is an ongoing initiative because it is very successful. Delaware, of course, is a small state. And they realized, looking at their numbers, that there were higher rates of colorectal cancer, advanced colorectal cancer in people of color in their population, and higher death rates. And so they brought together clinicians, public health experts, political leaders, patient advocates, patient navigators. They brought them together and said, we have to come up with a strategy. And what they did is they had an all-out blitz about the importance of colorectal screening. And they sent the patient navigators, the advocates, worked with the communities to increase the number of people being screened. And for those who were screened who had insurance, their insurance covered it. For those who were screened who didn't have insurance, the state covered it. And when they did the screening, if they found cancer, for those who had insurance, the insurance would cover it. And for those who didn't, the state covered it. And what they found is that they completely eliminated the screening disparities between Blacks and whites. They equalized the incidence rates, the amount of locally advanced disease in Blacks came down, and the mortality differences almost completely went away. And the program paid for itself and more. Because of course, if you can pick up early disease, it's more cost effective than having people to have advanced stage disease. And so the program paid for itself, and it also had money left over, and it's also paying for other programs. This is a very successful program. And now, of course, that we have a president from Delaware, we as an ASCO are trying to increase the awareness of this program to other states. So that they also can use this approach. So, what can we learn from Delaware? We can learn that healthcare is a community enterprise. When you bring together stakeholders, you bring positive change. And expanded access to screening and care improves outcomes and lowers costs to the system. So this was a win-win, is a win-win, it continues. And the third model, which is what I want to focus on, is the collaborative quality initiatives in Michigan, the Cqis. And these are initiatives that are supported by Blue Cross Blue Shield of Michigan. And these are physician-led collaboratives that are composed of physicians across the state. And these collaboratives collectively decide on treatment goals and best practices. And when practices achieve the goals that they set, the practices are rewarded by Blue Cross and Blue Shield. So these Cqis utilize comprehensive clinical registries where you have patient risk factors, processes of care, outcomes of care, and physicians, hospitals, and health systems collect the data, and we collaborate to measure and improve the standard of care in the state of Michigan by focusing on reducing errors, preventing complications, and improvement of patient outcomes. And this is something that started in Michigan, I think in the state of Michigan, late 90s, around 2000 or so. And they're in different disciplines. MSQC, which is a CQI of surgery, general and vascular surgery, was actually one of the first. It was part of the initial experiment by Blue Cross and Blue Shield in Michigan to see if it was going to work. And so again, they brought together groups of physicians that came up with initiatives, best practices, and they looked at the outcome. You could see that those who were in the Michigan hospitals and part of the collaborative did far better in terms of morbidity than those non-Michigan hospitals. And so this translated into improvement for the patients, and it also translated into significant savings to Blue Cross Blue Shield of Michigan. And so now I have 17 Cqis listed here. I think we actually are now up to 19, but you see we now have Cqis in all different disciplines. Surgery, we have medical oncology that's based on the ASCO COPE guidelines, cardiothoracic surgery, bariatric surgery. You see a value collaborative, you see a whole range of initiatives because these have been very, very successful for Blue Cross Blue Shield of Michigan. And I mentioned that not only do you see a lowered complication and mortality rate for thousands of patients, the cost savings are amazing. If you look at, this is just a snapshot of actually over 7 years, but only of a portion of the Cqis. It's not showing the savings from all the Cqis. But you see there was over a $400 million savings by Blue Cross and Blue Shield, which translated into a $1.4 billion statewide healthcare cost avoidance. So these are very, very successful. So the Cqis were happening. There was not a Cqi in radiation oncology. But of course, the cost of care in radiation oncology is increasing, of course. And one of the things that was very noticeable to Blue Cross and Blue Shield was the increase in use of Imrt, intensity modulated radiation therapy for breast cancer. And this was a paper that Ben Smith and some of us from Michigan and Harvard and MD Anderson wrote together, looking at the adoption of Imrt. This was back in 2011. This was also around the same time that Blue Cross and Blue Shield of Michigan called a meeting among the highest volume radiation oncology practices in the state. And then they brought leaders from these practices into their headquarters, and we had a meeting. And they basically said, Imrt is breaking the bank for breast cancer, some degree lung cancer, but they were really focusing on breast. And a discussion ensued among the radiation oncologists, and it became clear that there were some practices who used Imrt in almost 100% of cases, even their T1 and 0 tangent only cases. And there were other practices like Michigan who didn't use Imrt for breast. At that time, I had an R01 where we were putting together designing a Imrt algorithm for left-sided node positive patients, which we then put in a randomized trial against the best 3D. So it was part of my R01. So they heard me saying, we're not using Imrt unless we're on their patients are on my trial and compared to others. So it was shortly after that meeting, Blue Cross and Blue Shield called me and said, would you be willing to consider writing a proposal, you and your collaborators at Michigan and Radiation Oncology, putting a proposal. We won't say we will fund it, but we would very much like you to do it. So we did that. First, I found out what the Cqis were all about, and we submitted the proposal, and the rest was history. I mean, they made it very clear that if we didn't find a way to control costs, they would. And if they did so, it might not be in the best interest of individual patients. So we looked at this as an opportunity, and Imrt was established. And since 2011, Imrt has been a platform for both comparative effectiveness research and quality improvement. It is comprised of radiation oncology practices across the state of Michigan, where we work together to identify best practices and to guide appropriate use of high-cost technology in the treatment of patients with radiation. Our work has allowed us, I think, to move the needle clearly in a very positive direction with meaningful endpoints. And we started out with breast and lung, and because we've had success, we have now also moved on and included bone metastasis, as well as patients with prostate cancer. So we have 4 parts of Imrt. And this just shows a map as of 2021 of the sites across the state. Every time we have a meeting, we have 3 system-wide meetings a year, and we always update the map with practices. And this shows our mission to improve the quality of radiation therapy through patient-centered care, to expand, the vision is to expand access to high-quality care, and you can see the values. The values are patient-centered care, evidence-based care, and we collaborate and we are respectful of one another. And so our goals, the key goals here, we want to standardize treatment planning and delivery techniques. We want to develop best practices, guide appropriate use of high-cost technology, sustain growth, impact policy, and deliver equitable care. Here is the nexus of quality and equitable care. And so just very quickly, some of the data we collect details of the treating facility. You know, how many LINACs do they have? What type of simulator do they have? All those kind of parameters so that we know what equipment each facility has. We, of course, collect patient demographics, we collect patient comorbidities, tumor stage, and characteristics, and we get patient-reported outcomes. That is key. Of course, you have physician-reported outcomes, but you must have patient-reported outcomes. And then what is incredibly unique about Imrt is we have all the treatment planning and delivery technical details. And for those of you who are radiation oncologists, you know how important it is to actually know what was delivered, not just look at a prescription and say the person got 2 gray a day to, to 20 gray. You want to actually see what was delivered. So what we actually have the DICOM data. Jean Moran, who was the head of our physics group for many years before she left last year to go to Memorial Sloan Kettering, was the person who set up the physics infrastructure. She was at the very beginning of Imrt and has been there up until just a few months ago. And so we have a system where we get data from the EMR and we collect data from treatment planning systems, and they're sent into the consortium database. And then that data is uploaded into our site. We maintain all the data at University of Michigan. And we have 2-factor authorization, and we have a series of audits. We go out to the sites to make sure they're uploading data correctly. We do cross-checks of data, and we really need to be sure that the integrity and accuracy of the data is right. So it's a very, very sophisticated system to get quality data, including the actual data, the DICOM data that has been delivered. And by the numbers, we have over 18,000 breast patients. We have over 4,000 lung patients, almost 3,000 patients who have bone metastasis. And then we have over 1,000 prostate patients, which is amazing because we really just started the prostate initiative a few months ago. So just to give you, I'm going to just give you a few examples of the power of the CQI, what we've been able to do in radiation oncology. And when you set performance metrics and you have ways to track how institutions are doing, and there are ways to reward institutions, you really do change, and you really do affect change. And one of the endpoints that we've looked at with performance metrics has been the use of hypofractionation for breast cancer. And of course, this audience knows there have been randomized trials showing the equivalence in terms of tumor control with hypofractionation versus or conventional fractionation, and there are fewer side effects with hypofractionation. So for appropriately selected patients, this is the preferred option. And you see over the years with Imrt, you see when the performance measure was initiated here in 2015, you see how the numbers jump 32, 45, 73%. We're now up to over 95% of patients with the expanded criteria for hypofractionation from the more recent ASTRO update. You have excellent uptake of hypofractionation. Now, you can say that's not all because of the CQI, and you're absolutely right, because all the other communities in the US outside of Imrt are also increasingly using hypofractionation. When you look at this data by Parikh, who took data from multiple commercial health plans, you see that in 2012, there were 20% of patients, appropriate patients, were getting hypofractionation, where it went up to 80% in 2018. Look at us in 2018, we're up to 96%, and we have sustained this. And so if this is a representative sample, I don't know that it is a representative sample from the Parikh data, you see 80%, there's still an interval increase from having the CQI and having this as a performance metric. So one of our previous residents, she's now finished the program, did an analysis looking at whether hypofractionation was used similarly across racial groups. You know, we know this is the preferred treatment, but is everyone getting equal access to it? And what she found is that Black and Asian women were significantly less likely to receive hypofractionation compared to whites. And when she dug deeper, she found that one of the reasons, and perhaps the main reason, is that, of course, patients go to places, to facilities that's closer to them, either where they live or closer to where they work. And there was a clustering of patients to certain facilities, and these facilities were not using hypofractionation as robustly as other institutions were. So it's a reminder that we must all provide contemporary treatment recommendations independent of facility location. So all patients have the advantages of the latest advances in radiation oncology. So clearly that clustering made a difference. Dr. Reshma Jagsi looked at patient-reported outcomes by race in Imrt, and she found race-related differences in pain after correction for other factors, with Black women noting higher rates of pain than white and Asian women. And this is obviously very important because it reinforces that we need to ask our patients about their pain level and then provide appropriate treatments. And it's particularly relevant because, of course, it's more difficult to see early skin reactions in women of color than in white women. And so you may suspect that there's pain associated with a lot of brisk erythema in white women, but you don't appreciate it in Black women. So it's a reminder that we must ask and then address it appropriately. Anna Loshis, again, did analysis, this time looking at some of our lung cancer patients, and she presented it recently at the Radium Society a few months ago. And this was over 1,400 patients from 24 institutions. You see the stages there, you see almost equal distribution of male and female lung cancer patients. And what she found is, luckily, we saw that treatment type didn't differ by race, so that was very good to see. But what she also identified was that there were higher rates of general pain in lung cancer patients of color compared to whites, specifically at the end of radiation. And this data was actually pretty consistent with the work of Dr. Jagsy for our breast cancer patients. So again, we're seeing more pain. We need to ask and we need to address that. Another initiative that I'm very proud of from the CQI is looking at heart dose and tracking heart dose for left-sided breast cancers and making this a performance metric to encourage the reduction of mean heart dose. And the time we published this a few years ago, you can see that from years 2012 to 2015, there was a gradual reduction in mean heart dose for left-sided cancers, for breast only or breast and nodal fields. And I can tell you that this downward trend has continued to go down to a point. You can only go to a certain point, but is continued to gradually either come down or stabilize over the years. And when we published this, we looked at factors that were associated with increased mean heart dose, and also those that were associated with decreased mean heart dose. So increases, we found use of Imrt. If you don't have a heart metric to follow the planning of Imrt, in Imrt, you can actually increase your heart dose. So you need to make sure that you use that as a focus to drive down your dose. Use of a boost will increase heart dose. Regional radiation increases heart dose. Conversely, deep inspiration, breath hold, prone positioning, things that we know should reduce heart dose did in fact do it. And it's a reminder to our providers to, again, that there are certain things you can do in the planning that will significantly reduce heart dose. Dr. Christina Chapman, when she was at Michigan, wanted to look at heart dose by race and ethnicity. And I must say, I thought, okay, sure, you can do it. You're not going to find a difference. She did find a difference. She found that for Blacks, there was a higher heart dose than compared to whites. And when she dug deeper again, there was an association. This wasn't the only factor, but it clearly was in part because of treatment facility, that clustering effect where people were going. They were not going to facilities that utilized heart sparing techniques as often. So once again, a reminder that we must use the best possible approaches so all of our patients can have minimal toxicity and appreciate the benefits of technology in radiation oncology. And then a final example of just how powerful the CQI can be. I want to highlight this work from Dr. Martha Matuzik, who's now the head of our physics group, and her work and her committee's work within Imrt. This was an initiative to increase the use of respiratory motion assessment for patients with lung cancer. So for the non-radiation oncologists, we know, of course, patients breathe, and if you're going to treat a lung cancer and you don't follow the motion of the lung cancer, you could actually not include the lung cancer in your treatment field. You have to have some motion assessment tool so that you can track patients appropriately. And only 56% of our institutions had a motion assessment, managed motion, despite the fact that all the sites had motion assessment capabilities. There were some not using it for lung cancer. And so Martha put together a working group, and they visited the Imrt institutions to demonstrate the importance of motion assessment. They drafted a good practices document. They gave quarterly presentations at our consortium-wide meetings, and we had a metric for motion assessment. And what we saw is that if you look at where institutions were before these efforts and then look at where they went to, they all came up, so that we went to a consortium-wide utilization rate from 56% to 92%. This clearly shows the power of the consortium and improving practices of treatment. So this was the last time we took a group picture. This was 2019. We're bigger now. And this was at one of our consortium-wide meetings. We have radiation oncologists, we have physicists, we have dosimetrists, we have administrators, we have clinical data abstractors across the majority of institutions in Michigan. I would say at this point, we probably have somewhere around 2/3 of the radiation oncology practices are members of Imrt. So clearly the CQI is an excellent model for disseminating best practices that can benefit all patients, be they white, black, brown, rural areas, wherever, so that we can deliver equitable care. But of course, there are other components to delivering equitable care that are necessary. Whether you're a radiation oncologist, medical oncologist, surgical, whatever, there are other components. And certainly one of those is increasing enrollment in clinical trials. We know that the vast majority of adult cancer patients are not treated on clinical trials, and we know the numbers are woefully low if you look at patients of color. We also know that the percentage of cancer providers of color is much less than the percentage of people at large. If you look at the US oncology workforce, this was a snapshot taken by ASCO. They do this every year. 0.1% American Indian or Alaska Native, 3% Black or African American, whereas 13% of the population, 4.7% Hispanic Latinx versus 18% of the population, and 34% female versus 50-50. So we know that we need to grow the diversity of our workforce. So with regard to the clinical trials, during my year as president, ASCO and the Association of Community Cancer Centers, ACCC, we formed a collaboration, and it is ongoing, to increase the diversity in our clinical trial populations by trying to figure out where we're losing minorities. So this is a pilot in which we have developed a extensive questionnaire, and our pilot institutions have responded to the questions to see within their institutions, where are the barriers to putting on patients in clinical trials? If you say 100 African-American cancer patients walk in your door, but 2 go on clinical trials, where did you lose the other 98? And every institution is different. Everyone has different biases, has different barriers, excuse me. So these questions really go in depth so that you can look at the process in your institution. And the other piece is the implicit bias training to help sites mitigate implicit bias, acknowledge and mitigate implicit bias. So again, that does not enter into your thought process. You know, because we know, if you look at papers that have been published more recently by Joseph Unger, looking at a meta-analysis of the patients who go on cancer clinical trials, you see that if you ask, once you ask patients to go on trials, there's an equal percentage, be they Black or white, who will go on a trial. So you have to get them to that point where you can ask them to go on a trial. So we have to look at the barriers that are preventing patients going on trial so that we can increase the number of people who are being asked to go on a clinical trial. And I put this in here as what else we can do. We can all be strong advocates for access to equitable cancer care. And I think the best example is the Clinical Treatment Act. And for those of you who don't know this, what this is up until the end of 2020, Medicare and private insurance, they would cover the routine costs associated with a clinical trial. When we talk about routine costs, we're talking about seeing the physician, getting routine blood tests, getting routine radiology studies, you know, getting antiemetics, the routine kinds of things. Medicaid was the only major insurer that would not cover the routine care costs for going on a clinical trial. But paradoxically, if their patients were not on a clinical trial, Medicaid covered these costs. So it was a disincentive for Medicaid patients to go on clinical trials. And who are Medicaid patients? They're the poorest patients. They're the patients who can't afford to pay out of pocket for these routine care costs. So ASCO for many, many years advocated for this. It was driving me nuts. This just seemed to be so awful and so unfair. And I'm happy to say in December of 2020, a bill was passed and the Clinical Treatment Act was put into law, and it became effective as of January 2022. So it now is functionally effective, and ASCO is working with CMS and the states to help to implement this. But it just shows of what's possible with advocacy if you're willing to pick up that rock, if you're willing to challenge policies that have been in place that disadvantage one population relative to another. Things will change. It may take some time, but things will change. What else can we do? We need to increase the number of providers who are underrepresented. Now, when I say that, I'm not saying that every patient of color. Okay.
My apologies. Go ahead.
The fewest number of African Americans went into hematology oncology. So we need to do better to reinforce just how important and rewarding these careers are. And we see the same thing in terms of radiation oncology. This was a study using AAMC data and looking at faculty, underrepresented faculty in radiation oncology versus non-underrepresented minorities. And you see that the numbers are quite low. If you look at the curve on the left for underrepresented men and women in radiation oncology, you see that the numbers 20, 40, 60, it goes up to 100 on the y-axis. If you look at the one on the right, numbers go up to 8. And so clearly much smaller representation of minority faculty in radiation oncology. And I think it's important because if you have more minority faculty, you probably will get more students, you probably get more residents, you probably get more people to come into the discipline. And this was shown very nicely from the paper out of Imrt, again using AAMC data, looking at actually all of the specialties. And even though it's focused on radiation oncology, you can really look at all of them and look at for white, Asian, the bottom Hispanic, and Blacks. And if you look at the yellow lines being the percent of the general population, and then look at the percentage of the senior faculty, you see it is so low for Hispanics and Blacks, and it actually exceeds the percent of the population for whites and Asians. So again, there's a lot that we need to do to increase faculty so that we then can increase our trainees of color. And very nice experience that's ongoing in the Harvard program. They call it RISE, the Radiation Oncology Intensive Shadowing Experience. And basically what they're doing is they're creating a virtual platform for medical students who can't come and visit other programs because of the pandemic. A lot of the Black medical students are in places who don't have radiation oncology departments. And so in order to expose them to radiation oncology, there's now a RISE program where they go by a week. They have a student who can then visit the chart rounds, can actually visit morning conferences. They will do a project. They actually are able to mentor these people and bring them on board from afar. And experiences like this, I think, will improve our numbers. And then in ASCO, the year when I was president, we started the Oncology Scholars Rotation. And what this is, it's another way to increase medical students' awareness of the careers in oncology. And what we do is we have students between their first and second year of medical school, between M1 and M2 year. And ASCO does all the heavy lifting. Their institutions apply to be a part of the program. And if they're approved, their students can take virtual classes through ASCO for 4 weeks. And they rotate, they can shadow oncologists at their institution. And as I said, they get a stipend. And this is a way to really acquaint minority students who are often first generation college students and probably don't know a lot about oncology professions when they get to medical school, of really understanding more about the rewarding all the different types of disciplines within oncology. We're going into our second year this summer. Other things we can do, we have to be willing to have open discussions about racism in our training programs. We have to understand the barriers to treatment that our patients face every day. You know, we have to talk about racism in medical school, in residency, in fellowship. We have to talk about the importance of cultural competence. And we have to realize that the changes, the differences we see in terms of the inequities are not all due to biology. Biology is very important, but clearly there are the invisible factors, social determinants of health, the barriers that our patients are facing. We must acknowledge that and address that the best we can. And as health professionals, we need to acknowledge the past and current racist policies. We just have to say that there have been, without a doubt, racist policies, and they are not over. They still happen in parts of the US. Racism it's not going to go away overnight, because it certainly didn't get here overnight. And so we really have to be ready to call out and talk about this. And I will say, in my experience, one of the only positive things about the pandemic and about a lot of the violence that we've seen is there seems to be a much more serious dialogue, that people are ready and to talk about the issues. These are tough issues and they have to be discussed. So another initiative that I started when I was president is we had a social determinants of health set of podcasts and videos, which was trainings for early career oncology providers. So I put together a advisory group of fellows and early career oncologists, and we came up with topics that we wanted to have podcasts to really explore more in depth. And we did this pretty much every month, and the initiative has now been completed. The podcasts and videos are available for those who want it. And I think the program, we got a lot of positive feedback, and I think ASCO is going to continue it in a different version. But one of the most helpful podcasts, I think, was how to take a social determinants of health history. Of course, we've all been taught in medical school how to take a history, but are we asking the right questions? And it really outlined the things that we really should focus on and take the lead from the patient. So I am very proud of the work that ASCO has done and continues to do in the equity space. As long as ASCO has been ASCO, they have done equity work. But we clearly increased our portfolio over the past couple years. And they reorganized things such that the EDI efforts are now embedded in the 3 pillars of our strategic plan. So education, research, and quality. And I have always thought that that's very important. I don't think, in my opinion, it's difficult to have a successful EDI initiative if it's an add-on. I really think that it has to be fully embedded in the organization. And that's what ASCO has done. They have really embedded EDI in the fabric of the organization. And I don't have time to go through all of the initiatives here, but if you look carefully at much of the work that ASCO has done recently and their EDI approaches, you will see that they are fully a part of the organization. So to finish up, do we have all the answers for reaching equity? No, of course not. But sometimes it's not about having all the answers. It's more about posing the right questions and searching for the answers together. It's a journey. This was a comment that I made that got turned into a slide. I didn't put the background on it. That was ASCO. They're far more creative than I am. But I just really think that this is the right time. We are at the right time to really deal with these tough issues. And I mentioned earlier that when I came up with the theme of equity, I didn't know how receptive the oncology community was going to be. The oncology community could not have been more receptive. The response has been just so gratifying. So I'll end where I started. Equity, every patient, every day, everywhere. We're all committed to equity, and I know that commitment will continue for many, many, many years to come. So I will stop and happy to answer questions.
Thank you, Dr. Pierce. That was wonderful. To the audience, if you have any questions, please use the Q&A feature located at the bottom of your screen. While we wait on questions, I wanted to mention that next week we will welcome the Clinical Trials Office, who will present their quarterly critical updates in clinical research. To view all upcoming Winship Grand Rounds lectures, please visit the Grand Rounds page on the Winship Cancer Center website or the Winship calendar. So we have a couple of questions coming through, but I did want to get us started with one. In those facilities within MROC where there was clustering and less of an adoption of hypofractionation and motion management, and those patients that were typically served there were African American or Asian. What were the specific barriers to adoption of hypofractionation and motion management? Was it resources? Was it lack of awareness of those technologies and advances in the field? Can you put your finger on what were the challenges and barriers?
Certainly the lack of awareness of the benefit of motion management, which was surprising to me, but we have to remember we're in major academic centers, right? One of the beauties of Imrt is you get a cross section of practices, and people aren't up on all the literature like perhaps we would be. And so actually showing them how this tumor moves and how when you manage it, your treatment field will take that into consideration. It was awareness. And as I mentioned in the talk, these are facilities who actually had the equipment. They just didn't, they weren't. And with the hypofractionation, I think in some cases, some programs perhaps weren't aware of the data showing less side effects. And there, to be fair, there were probably some who, because of reimbursement, if you're going to be giving a shorter course, you're going to get less reimbursement, depending upon how your insurance covers it, than a longer course. So there was a little bit more hesitancy, but after a while, it just became clear that that was the way to go, and people came aboard. So I think it was a multitude of things. Part of it was a lack of awareness, and perhaps some of it was a bit on the reimbursement side. So it makes me really, really proud of Imrt, because many of the initiatives will bring in less reimbursement. It's the right thing to do, and that's what people have come around to doing. So
it's amazing. All right, a few questions in the Q&A. So Dr. Bradley says, great talk. Thanks for being with us this morning. In your opinion, which patient should get IMRT for breast cancer? You mentioned that you don't routinely use it. Then you mentioned the hard dose was extremely important. And I think this is a very pertinent question given the recent MROC publication, the Red Journal that just came out recently. So
yeah, so a great question. So at the time that we did this, we were, like I said, not using IMRT except that they were on my trial. We now know it's been interesting in that how you define IMRT is so variable. And for the radiation oncologists, I'm sure you understand that. And so when we first looked at IMRT, we didn't see a benefit. But when you looked at those who were inverse planned, where you actually have dose constraints and you're working backwards, that's where we saw the benefit. So I think you really need to look at those patients where if you're treating regional nodes, you've got a left-sided cancer, the proximity of the internal mammary nodes to the heart, that those may be cases where IMRT clearly gives you a better. You need to do the best 3D, look at the best IMRT and make a decision. But I think you're hard pressed showing it for a T1 and 0 right-sided breast cancer. I don't think you can make the case for IMRT. So I really think you have to have heart constraints. But in our earlier analysis where we showed a higher heart dose with IMRT, it shows if you don't put a cardiac dose constraint on, you actually can drive up the dose with IMRT. So you really need to do inverse planning.
Yeah, and it really speaks to comparative planning too, to make sure you're using the right tool for the right patient.
Right.
Okay. Dr. Waller, again, also says, wonderful talk. He's grateful for your insights into improving accrual of minorities under clinical trials. Looking back at your talk at the Nixon Library, the curves for cancer death rates of whites and blacks look like they were converging with the lines crossing about in 2020. Has that occurred? What were the biggest drivers in improved death rates?
So you still see a difference for blacks. Like the death rates have come down for blacks, for sure. They've actually come down more for blacks than for whites because we were starting at higher. But you still see a difference. So there's still much work to be done, and it's multifactorial. Some of this is early detection, some of it is lifestyle changes. You have, depending upon the cancer, you have to figure out what the causes are, but there still very much is a difference in outcome by race.
Dr. Lawson asks, if I understood correctly, about 2/3 of radiation oncologists in Michigan are in your MROC program. Yes, what's up with the other 1/3? Do you think they are worse on quality indicators, equity, et cetera?
What a great question. No, I don't know past with indicators. There is a nervousness that some people have when they first come into Imrt, and then it goes away. Just how much does Blue Cross and Blue Shield, how much do they need to know? I mean, we have it set up where Blue Cross and Blue Shield can't see individual hospital results. They see the aggregate. You know, that we don't share with the contractual agreement. They don't get the institutions, but there's still a paranoia that Blue Cross and Blue Shield could see too much, quite honestly. And then there's also a paranoia where if institution A does better than institution B, is institution A going to advertise that across the state? That's also an agreement we have when you come to Imrt. There will be no broad-based comparisons. So we have ground rules, but there is still a bit of nervousness. And then third, it's work to put in data for this. And Blue Cross and Blue Shield covers, I won't get into too much of the granular data, they cover 80% of the cost of a data manager to put these data in. They don't cover 100% because some of the patients aren't Blue Cross and Blue Shield patients. They're covering all the patients. So if they're covering all the patients, they're not going to cover 100% because it's not all Blue Cross and Blue Shield. So they've made 80% as their cutoff for the salary they will cover. So the institution has to put in that 20%. And what many institutions do is they use existing dosimetrists and they add to their work. Some people do incremental hires, but you do have to figure out a way to cover that 20%. So I think that's part of it, but I think part of it is just stubbornness and paranoia, quite honestly. But thank you for that question.
All right, Dr. Janipal Naylor is the resident that you featured his work in your presentation, so thank you for that. He writes, terrific talk. Where do you think there's funding for these types of projects? I believe he's talking about equity inclusion. Also, what do you think is the best way to address the multidisciplinary patterns of care? Is NCDB sufficient? Should we expand MROC scope? I guess he's saying more nationally or something else. And thank you so much for being with us this morning.
Yeah, no, I get asked a question, and I think that may be part of the question. How do you have maybe more MROC-like registries? And it's a great question. You know, part of this is you have to have resources, right? If you're going to be doing the work, and especially with a lot of the dense data that's collected from radiation, you got to have money for salaries. You got to have money for incentives. And so is it possible to do it other ways? Yes, it'd be great. Instead of having the CMS directed radiation oncology model that we're going to all have to follow, I'd rather them use models that have worked. Imrt, the Cqis have worked. The Delaware project worked. I actually made a presentation to them saying, before you roll out this radiation oncology model, why don't you look at things that actually have been shown to work right? Didn't go over well, but you still try anyway. I think that it could work through the government, but I think it's much easier to work with insurers. And Blue Cross and Blue Shield, we're in the one in Michigan. They each are state specific, as you know. And I think a lot of the other states have looked at some of the work that we've done. And I would hope that this could be replicated with other Blue Cross and Blue Shield, other insurers across the country. So anyway.
A couple more questions. Dr. Asta writes, what's the priority work that is being done to maximize equity in cancer care? What cancer is being tackled first?
What cancer is being tackled first? I mean, wow. You know, given we have a range of cancers and given we have a range of outcomes, and generally the outcomes are less favorable in general for people of color, I can't say that we're tackling one. I mean, obviously in Imrt, you've seen we've taken the big ones, the breast, prostate, and lung. But I think from an ASCO perspective and advocacy perspective, we've not picked out a single one. We're advocating for changing health styles and changing lifestyles and really tackling them all. I can't say that we could pick one versus another.
Makes sense. Dr. Alisi writes, thank you for your leadership at multiple levels. There are ongoing conversations about insufficient data supporting a biological basis for race, but that some of the well-defined disparities are geographic. What is your view about this?
So I'm sorry, the question about that, did you read the first part of the question again?
Sorry, I choked a little bit. There are ongoing conversations about insufficient data supporting a biological basis for race, but that some of the well-defined disparities are actually geographic. What is your view about this?
We certainly, race is a social construct for sure. I think that's what you're getting at. I completely agree. And so we have to really get at the factors. I mean, I always tell my residents, we give cancer cells far too much credit. They can't tell if we're white, black, or purple. I mean, we just give them far too much credit. So it's really the mechanisms, right, that really drive this. And so what are the drivers of those pathogenic pathways? And I think there's more and more, I know there's more and more research looking at social terms of health, how they can impact the biology. So biology is a part of it, but clearly stressors and environmental pollutants and all those kinds of things are part of it as well. So I completely agree with your question. It's not about race. Race is a poor surrogate for something else, and we're still looking for that something else. Right?
Completely agree. Well, I think we covered all the questions. You generated a lot of interest clearly. Thank you so much for being with us today. I really appreciate that. And that will close our Winship Grand Rounds, and we will definitely be in touch, Dr. Pierce. Thank you for spending time with us today. It was an honor.
Take care. Bye-bye.
All right, bye now.